So here's respiratory. As you can tell, I use the talks to supplement and expand on things. I do count on you guys to look up the medications, try to understand them, bring your burning questions to class and talk about them, and use the supplemental videos to get more of the details. So I did include a concept on here for acid base. I do think it's really important. I know it's not directly related to pharmacology, but I do think that for the few slides that we're going to do, it's important enough to cover. So oxygen is good. So the respiratory system, everything we do with the respiratory system is intending to get oxygen to the cells. We try to provide more airflow to the lungs. We try to provide optimization. Now, in what we're doing with this, really a lot of what we're doing is related to acid base. And I'm going to talk a little bit about this. I'm going to talk a little bit about microbiology. And all of these things are critical to understanding respiratory, although I'm going to just mention a number of these medicines. So, short chemistry class, water plus carbon dioxide combines in the body to form H2CO3, which is carbonic acid. It then breaks down into bicarbonate and a hydrogen ion. So if you have a lot of carbon dioxide in your system, it will increase the amount of carbonic acid that's produced, and it will create the bicarb and the free hydrogen ions, which increasing free hydrogen ions increases the acidity in the body. The equation can also be run the other way in someone who is diabetic and they become ketosis. They basically stop taking their insulin, and because they're not taking their insulin, their cells switch over to an anaerobic metabolism, which produces a lot more hydrogen ions. If they have a lot more hydrogen ions, those hydrogen ions bond with bicarb, which is a buffer system in the body. That then produces carbonic acid. That then dissociates into water and carbon dioxide. So that patient will pee more, and they will actually breathe faster to try to get rid of that carbon dioxide. So a lot of what goes on in the respiratory system is related to acid base. So just to remind you that acid is just free hydrogen ions, and so basically it's a negative logarithm. So if this is not literally true, but it is conceptually true. So if a pH of 1.00, this is a pure acid. 0.1 is basically a pH of 2. We move the place to the right. 0.01 is a pH of 3, and so the normal is 7, and so normally the pH is about 7 places to the right of the decimal point. The lower the number, i.e. 1 is very acidic, 2 is a little bit less acidic, 3 is less acidic, and 7 is considered to be neutral. Anything above 7 we actually consider to be alkaline because it's lower than the usual pH of the body. So basically, again in English, water plus carbon dioxide creates bicarbonate and acid. If you've got too much CO2, you'll get too much acid. So this would be a respiratory acidosis. So if you have a patient who is retaining carbon dioxide, they'll end up with more carbon dioxide in the bloodstream and they will become acidic. And if you get too much acid, such as the example we just gave for diabetes, you'll try to blow it off as carbon dioxide. So to make yourself acidotic, all you have to do is hold your breath, and that will increase your amount of carbon dioxide. You become acidotic. To make yourself alkalotic, you breathe fast. Hyperventilation actually causes an alkalosis. Usually patients will pass out and then return to a normal breathing level. But sometimes we actually have to have them breathe into a paper bag because their body is getting too alkalotic. This will cause tingling around their mouth. It'll cause tingling of their fingers. Their mentation actually decreases. All sorts of things happen. So to check what the status is in the body, we can do arterial blood gases, ABGs. Again, not something that we'll be using pharmacology for, although again, if someone is acidotic, we can actually give them bicarbonate, which will bind with it and improve the pH and so on. So we breathe to not only get oxygen for ourselves, but also to rid ourselves of the carbon dioxide. Well, what happens if you can't get oxygen in or carbon dioxide out? This is an example of some of the nursing diagnoses that are related to that. Great post on the discussion board talking about correlation to nursing diagnoses, and I think it's a really great opportunity for you to start thinking about this. So let's talk about Kim. She's 16. She gets wheezy when she goes to her grandmother's camp. She gets wheezy after soccer practice. She's been diagnosed with asthma. So she's been started on an albuterol inhaler. Well, albuterol is a short-acting beta agonist. It's supposed to open up the bronchi. And basically, we see that what's happening in asthma is bronchospasm. Usually it's a reactive airway disease. It constricts down, and so we open it up by giving a short-acting beta agonist. We also know that there's some inflammation there, and so sometimes with asthma, we'll give an anti-inflammatory, such as a steroid. There's edema, there's mucus. Sometimes to try to dry up the mucus and also to stop the bronchospasm, we'll get a long-acting muscarinic antagonist, a so-called LAMA medicine, an anticholinergic, but we can attack asthma in a number of different ways. Those LAMAs are not really approved for asthma, but you'll actually see them used on a fairly regular basis. So what can trigger asthma? Well, we know aspirin can, probably through the prostaglandin effect that it has. Allergens, pollen, those kinds of things, cold weather, sulfites, which are in certain foods, especially red wine. They're also sprayed onto salad bars at restaurants to keep them looking fresh. This is something that I think a lot of people don't know, and unfortunately, if they are allergic to sulfites, they can get a reaction when they go and have a salad at a restaurant, even though eating a salad at home doesn't cause any problems. Beta blockers can actually stop them from getting that bronchodilation that they need, and therefore they get the spasm and they can actually get a asthma attack. So when you have asthma, you'll wheeze, your respiratory rate will go up, your heart rate will go up, you'll use your accessory muscles, you'll get fatigued, you'll get anxious, and often you'll have difficulty breathing and also have a cough. There is such a thing as cough variant asthma, in which the only symptom the patient has is cough. Status asthmaticus is when the patient is unable to break an asthma attack using the usual inhalers. Sometimes these patients will actually become hypoxic, which for all intents and purposes is the same thing as hypoxemia, even though there is a couple of cases, certain types of poisoning in which you'll have one but not the other. But for our purposes at this point, we can consider them to be synonymous. Hypercapnia is a fancy word which means high CO2 in the body, and this high CO2 will cause acidosis, right? So this patient is becoming acidotic. So what would be the treatment? Well, the usual treatment is injectable epinephrine if you have someone who has static asthmaticus. So you have to get some bronchodilation. Unfortunately, you'll also get a pretty fast heart rate and some other side effects. In general, the treatment for asthma includes this beta agonist that we're talking about, sometimes a long-acting beta agonist as well. Sometimes an anticholinergic. We'll often give the patient a nebulizer that has both a beta agonist and an anticholinergic, which we're using as being synonymous with a long-acting muscarinic antagonist here. So a duoneb, or, if you're given an metered dose inhaler, they call it Combivent. We'll also decrease inflammation using steroids. We used to use mast cell inhibitors on a fairly regular basis, the cromolyn. Now the only use for it is as a nasal anti-inflammatory that you can get over the counter. We don't usually use it. I actually had pretty good luck using it with some of my asthma patients, but I guess that not everybody did. So if someone has an infection, then if it's just in the bronchi, it's bronchitis. Bronchitis doesn't necessarily require adventitious sounds in the lungs, crackles or wheezes, but it often does have those. If you have a deeper infection, which is affecting the actual functional tissue of the lung, that is pneumonia by definition. Usually those people are sicker. They show consolidation on an X-ray, although it is not required to have an abnormal X-ray to have pneumonia. Pneumonia is a clinical diagnosis. So various kinds of pneumonia exist. Bacterial, which of course we would use antibiotics for. Viral, which we might very well use antivirals for. Mycoplasmal pneumonia, which mycoplasmal organisms lack a cell wall, so we would have to use certain antibiotics that don't involve cell wall synthesis inhibition. There's also some protozoa that cause pneumonia, such as Pneumocystis carinii. This pneumonia is usually associated with AIDS or immunosuppressed patients. And I think they've actually recently changed the name of the organism, so we should double check on that. Aspiration carries in bacteria. Sometimes you need antibiotics for that. So just to review, the most common cause of bacterial pneumonia is strep pneumoniae, which is actually a gram-positive cocci. It's a alpha hemolytic strep. It's unlike the beta hemolytic strep that we use that you get strep throat. So it does have a lot of very different characteristics than strep throat bacteria. But it is gram-positive, and therefore the organisms that hit gram-positives would be the best choice. Staph aureus would be an unusual cause of bacterial pneumonia. Usually the patient can fight this off on their own, so it usually only occurs in patients that are immunosuppressed. Gram-negative bugs are a lot harder to treat, obviously, so gram-negatives are a bit more of a challenge. Smokers tend to have more gram-negative bugs, and you would require an antibiotic that had good coverage for gram-negatives. Legionella is gram-negative rod. It's waterborne. Often those patients have confusion and diarrhea. If they don't have confusion, they might actually have something called Pontiac fever, which is the same bacteria, but not as severe. Again, for Mycoplasmal pneumonia, also known as walking pneumonia, they'll have a dry cough for 3 weeks or so. The other thing that often will cause a dry cough for 3 weeks or so is pertussis. And so that's why we use macrolides. It's because macrolides have great coverage for both mycoplasma and also for pertussis. I don't know what antibiotics are. That should say antibiotics. Sorry. Viral pneumonia, influenza is the most common cause, and two different medicines that we can use for that. Oseltamivir is Tamiflu. It shortens the infection of flu by about half a day to maybe even a full day, and you have to take it for a full 5 days. Zofluza is a new medicine that has just come out. It's baloxavir. I have not actually seen a patient on it yet. I've prescribed it once, but the pharmacy didn't have it. And it promises to be a lot more effective, but as with any new drug, I think we have to wait and see. Herpes infections, most commonly varicella, can cause a very nasty pneumonia, and this is one of the reasons that we are trying to make sure that patients are immunized against varicella. Just because when you get varicella when you're older, in your 20s and 30s, the risk of pneumonia goes up substantially. And again, the usually valacyclovir or any one of the antivirals would be a good choice for that. Measles can also cause pneumonia, and again, this is another reason to immunize. Protozoa, we'll talk about that more when we talk about AIDS. Protozoal infections in the lung are pretty unusual. Aspiration pneumonia, you get stomach contents and acid, and so anything that might be in the pharynx can cause that kind of pneumonia. So we treat most pneumonias with antibiotics. Viral pneumonia doesn't have to be, although the concern there is that with all of the inflammation that you may develop a bacterial infection on top of the viral infection. So sometimes we will cover them with an antibiotic. We try to liquefy and clear their secretions. Guafenicin has mixed evidence as far as its benefit, but we do usually try that. That's Mucinex. My experience has been that some patients do absolutely great with Mucinex and some don't find any benefit at all. Mycobacterium tuberculosis, MTB. Again, a mycobacterium is halfway between a bacteria and a fungus. Mycoplasma, sort of halfway between a virus and a bacteria. Mycobacterium, halfway between a bacteria and a fungus. So much more difficult to kill. Fungi have an incredibly thick cell wall, and it's much more difficult to kill them. So people that are immunosuppressed get tuberculosis, or people that are exposed to a large number of the tuberculosis bacteria. There is a group of people in North Korea right now that have extremely resistant tuberculosis, and unfortunately, just because of the amount of exposure, there's large numbers of people. TB goes in through the lungs, the macrophages eat it, but really can't digest it, so it really creates these cavitations, these pockets in the lungs, especially in the upper lobes. So it'll create a sealed off colony of MTB. MTB can infect other parts of the body as well. You can get tuberculosis in your kidneys, you can get tuberculosis in the spine. We used to refer to that as consumption of the spine. Back in the 1900s. If anybody's ever seen the play The Importance of Being Earnest, that's actually a literary reference there. But tuberculosis can be a very difficult infection to get rid of. Night sweats is sort of a classic sign of TB. It also is a sign of some cancers, including lymphomas. It's a relatively non-specific sign, though, because a lot of patients get night sweats for no good reason. I think a lot of patients get them because they have blood sugar issues during the night. But spitting up blood, hemoptysis, is definitely a concerning sign of TB. And again, one of those things that when somebody has hemoptysis, TB should always be on the list. Tuberculosis requires multi-drug treatment. INH is usually included. Sometimes when we have a patient who is just PPD positive but really doesn't seem to truly have TB, we'll put them on just INH. But if someone truly has a TB infection, they're usually on 2, often 3, and maybe even 4 drugs, depending on how resistant it is. So let's talk about COPD. COPD is chronic obstructive pulmonary disease. Lots of people have it. It's increased over the world because more and more people are smoking, and it's a major cause of disability. I don't know if you've ever seen anybody in end-stage COPD, but I think it's a much more difficult death than most cancer deaths, sadly. Just because they have air hunger, they can't breathe, it's very unpleasant for them. So most people, it's because of smoking. There is air pollution. There is also a genetic component in some people because they have an alpha-1 antitrypsin disorder. We can now test for that genetically, and they can actually replace the alpha-1 antitrypsin, but it is very expensive. It's $30,000 or $40,000 a year. So if you have somebody that has severe symptoms, it is worthwhile doing, but in a lot of people, it's not worth the money. So really, COPD is 2 diseases, and sometimes a third's added onto it: chronic bronchitis and emphysema, and then sometimes those patients will have asthma as well. Chronic bronchitis is a cough for at least 3 months for 2 years in a row, decreased ciliary function, thick mucus, and lungs with adventitious sounds, especially in the morning. Emphysema is loss of the alveolar walls and loss of the elastin. In some people, this may be related to alpha-1 antitrypsin deficiency. And most people that have COPD become thin. They don't absorb nutrients as well because they get dyspneic. They stop eating. They can develop a barrel chest, and they'll have distant breath sounds. Treatment for emphysema, generally because it's an obstructive issue, the issue is not all that much helped by dilating the bronchi, because what happens is they dilate, and then as you're breathing out, they collapse. So one of the things you can do is pursed lip breathing, and that'll decrease the amount of collapse. But also, if you block those muscarinic receptors, there is less of a collapse. So really, long-acting muscarinic antagonists are a foundational part of treatment for emphysema. Not everybody uses them, but if you look at something, there's something called the GOLD guidelines, which are the global guidelines for COPD. They really do recommend anticholinergics as first line. You can also use other bronchodilators, things like a long-acting beta agonist, things like steroids will decrease the inflammation, and steroids also increase the sensitivity of the beta-2 agonists. So, there's real benefit for steroids in these folks. Interestingly, steroids in COPD really don't seem to improve their numbers. It doesn't improve their lifespan, but it really does improve their quality of life. So there is benefit. We have low threshold for antibiotics in people with COPD. If you have somebody that has COPD, going from bronchitis to pneumonia can be really quick. And so if you have somebody with an exacerbation of COPD, we always put them on antibiotics. Even though with people that don't have COPD, we're trying not to use antibiotics. People with COPD is an exception to that. They might retain CO2. We'll talk about that in a minute. When they retain CO2 chronically, they're chronically acidotic. So the usual stimulus to breathe is high CO2 levels. So if you hold your breath, your CO2 goes up, and eventually you'll go, and oh my God, I got to breathe. Well, the problem is that in people with COPD, sometimes their CO2 levels are chronically high. So their body actually switches over to something called the hypoxic drive. So really it's the low level of oxygen that's really the stimulus to breathe. The problem with this is that because low oxygen is the stimulus to breathe, if you give them extra oxygen, they don't have that stimulus, so they start breathing more slowly. When they breathe more slowly, they increase their amount of CO2. Their CO2 actually, when it gets higher and higher and higher, almost acts like a general anesthetic. So they start becoming more obtunded, they start becoming more confused, and they actually can get to the point where they will actually die from too high CO2 levels. So a couple of other respiratory diseases, cystic fibrosis. I'm not going to talk about pneumothorax in this talk, so strike that. So cystic fibrosis is a genetic disease. It's an abnormal secretion from the exocrine glands. And so basically you have exocrine glands in a number of different organs. These are glands that secrete not into the bloodstream, but somewhere else. So in the pancreas, you secrete enzymes that are trying to break down food. People with cystic fibrosis do not have that ability. So in people with cystic fibrosis, they often will develop really thick mucus in their lungs to the point where it'll block the airways. So let's talk a little bit about Anna Mercurio. She's an 83-year-old woman. She's a widow. She was told 10 years ago that she had emphysema, so she probably has COPD. She's been admitted to the hospital for an exacerbation of COPD. She's a non-smoker, but her husband and son are both smokers. Her temperature is 102.4, which for an 83-year-old woman is a rather ominous sign. Pulse is 115 and is irregular. She's only satting at 89%. So obviously this woman will need a number of different interventions to make sure she's getting enough oxygen, as well as probably need some antibiotics to treat that pneumonia. So she's going to get some Rocephin, which is a antibiotic. It's a third generation cephalosporin. So it has broad coverage for whatever might be ailing her for her respiratory infection. We'll get a sputum culture so that when the sputum culture comes back, we can see exactly what bacteria she is growing and what is the right medicine for it. We'll do blood cultures to see if the bacteria has gotten into the blood. We'll usually give her duonebs, which are a combination short-acting beta-agonist and a short-acting muscarinic antagonist. In an MDI version, meter dose inhaler version, this is Combivent, but when we're giving it as nebulizers, it's called duoneb. Solumedrol will decrease the inflammation. This is an intravenous steroid. We'll give her some oxygen. We'll try to keep her energy level up, but give her a lot of rest by keeping her on bed rest with bathroom privileges. She'll eat a regular diet, but needs small meals because she's not able to eat as much because she gets short of breath. And really, much of what we have to think about when we're talking about respiratory goes back to the autonomic nervous system. So just review that if you're not comfortable with it all. And here's some drugs of the week. There's a bunch here. I'll post these on Blackboard for the respiratory week.